Hello and welcome to the Brain Matters podcast, brought to you by the Florey Institute, Australia's largest brain research centre. I'm your host, Dr. Shane Huntington, and together we'll be exploring the fascinating world of brain health. We'll meet leading doctors and researchers and learn about the reality of a range of brain and mental health conditions from people with lived experience and their carers. In this episode, we'll be exploring the inflammatory disease multiple sclerosis. What causes the immune system to turn against our own nerve fibres, damaging many parts of our body, including the brain. How does that affect people living with the condition, and what does the future hold for treatments? Joining me today to discuss this important area will be Catherine, a 55-year-old MS patient. Catherine will tell us about her personal experience living with MS for over 20 years. She happens to be a medical doctor and has an interesting perspective on living with a chronic condition. We'll also speak to Professor Trevor Kilpatrick from the Florey Institute, also a neurologist at the Royal Melbourne Hospital, who first began treating people with MS back in 1995 and who is now a leading clinical researcher. And finally, from the Florey Institute, we'll have a scientist, Michele Binder, who is researching the fundamental science that drives MS disease progression with the goal of discovering new treatments. Trevor, before we speak to Catherine about what it's like to actually have MS, I wanted to get your sort of take on just a clinical view, if you will, of what multiple sclerosis is and what happens in the body.
Thanks, Shane. Multiple sclerosis is the commonest neurodegenerative condition affecting young Caucasian adults. It affects approximately 1 in 1,000 people. It's more likely to occur in women than in men, ratio of approximately 3-1, and most commonly affects people first in their 30s. And most people have two phases of the disease, one which we call relapsing and remitting disease, which characteristically lasts between 10 to 15 years. And then between 50 to 75% of people untreated are susceptible to a second phase of the disease called progressive multiple sclerosis. And if we look at the relapses, they can affect any part of the central nervous system. Typically, they can affect vision, brainstem function, or the spinal cord, which can influence people's mobility, their ability to sense the environment, or occasionally also influence their cognition. Now, usually these relapses remit spontaneously, but they also can be severe and occasionally can lead to permanent disability of themselves. Now, over the last 30 years, there have been a number of treatments which now can inhibit the ability of these relapses to occur. And those treatments range from moderately to very effective, reducing the chances by up to 70%. And we also know that those treatments can reduce the propensity to some extent for progressive disease to occur, which has been a boon for many, many patients. Unfortunately, once progressive disease occurs, none of the treatments that we currently have really are very effective at inhibiting that progressive phase of the disease. And that's where much of our research currently lies in terms of trying to inhibit that progression. We also know that multiple sclerosis can be very variable. It affects people in different ways. And one of the challenges for us is at disease onset to be able to predict those who are going to do better as opposed to those who are going to do worse, because we'd like to stratify our treatments accordingly. And we're not there yet in terms of being able to predict that. And that's another challenge for us in terms of the research that we're undertaking.
Yeah, interesting. Catherine, if we go back 20 years or so, something was obviously happening to you physically. Tell us what that was like. Like, what were the first indications that something was wrong? And you're a doctor yourself. So
I am, and it was actually in clinic that I noticed a problem. I found quite suddenly that the process of walking in from the hospital car park to the clinic meant that I couldn't read the computer when I first got there. And it took a few weeks before I recognised that it was only a transient problem. I really wasn't putting it all together. And then very suddenly over a few days, it got dramatically worse, such that I was non-functional from a visual perspective if I did the least bit of exercise. And I spoke to the physician in the next room and said, I don't know what's going on. And she said, oh my God, you might have glaucoma. We better get you to see the eye specialist. And boy, I wish I'd had glaucoma. But anyway, I saw an eye specialist at the hospital I work at. She sent me out to see her in her private rooms the next day, having not been able to find a problem. And it was actually she who recognised that what I had was optic neuritis in both eyes, which is inflammation of the nerve that supplies the eye. She wasn't a neurologist and didn't examine me otherwise, and therefore didn't recognise that I had about 100 other things wrong, or my reflexes were off, and all sorts of things that I didn't notice at all. But she did recognise I needed an MRI and a neurologist, and she organised those things. And to cut a long story short, I didn't get a diagnosis straight away because I saw a neurologist who didn't do a lot of MS and who thought you needed to have 2 discrete attacks to qualify. But a while later, when all sorts of things were going wrong the same year, I saw Trevor. He kindly fitted me in one morning. I remember the comment he made was, I don't like to give a prescription at a first appointment, but I sense you're ready. And I think he knew that I was someone who was just desperate for a diagnosis because I knew what was going on.
As a clinician, how much sort of self-assessment did you do? Because I can imagine, like, even the way you described that, I'd be thinking, well, maybe you've got a migraine, after exercise. Maybe there's a whole lot of things that can affect your vision, especially after exercise. People feel dizzy. There's all sorts of things. Did you find that got in the way for you being a clinician? Did that delay things?
Yes and no. When I think back, the very first time I noticed visual problems was actually at the gym. I used to be on a cross trainer working out, and I noticed that watching the televisions at the front of the gym got blurry if I got my heart rate over 120. And I'd been noticing that for weeks. And as a physician, I'd been thinking, I wonder if I've got a cardiac problem. And if I exercise any faster, I'll actually faint. So being the sort of person I am, I pushed my heart rate even higher and I didn't faint, and so I ignored it. I thought, I don't know what this is, but it's clearly not life-threatening. And it wasn't until my vision got dramatically worse and I couldn't work effectively that I took it further. So I don't know if it would have helped to be picked up a few weeks earlier. I suspect not. But I doubt Trevor gets many MS patients who tried to push themselves into a cardiac blackout when they thought that was what was going on.
Yeah, it's probably not the normal way to go. I think in terms of the vision, though, describe what was happening there, because I actually have a family member who found out the same way, vision problems while playing basketball, and then ended up with a neurologist. I think she thought she was having a stroke at the time. What sort of vision changes were you seeing?
It's something that I think from talking to other people with MS does vary a lot. I, in retrospect, had an episode right back in the 1980s where I had what I'm sure was optic neuritis in my dominant eye. And at that stage, I was still at Melbourne University studying, and what I noticed was that when I was walking between buildings to get to different lecture theatres, I didn't recognise faces. So people would be walking towards me and I didn't recognise people I knew, and I got pulled up a few times for being unfriendly. And then I noticed that when I got to the lecture theatre, I couldn't read the whiteboards. That was in the days before PowerPoint. And I used to sit in the back row and I had to switch to sitting in the front row. So I actually have a really interesting group of medical school friends because it's the back row sitters and the front row sitters, which were the two places I sat. And that resolved after about 2 months. So it was classic for a self-resolving episode. When I've had optic neuritis since then, a couple of things happen. Your contrast vision for me goes right down. So what that means is I might be able to read something that's black on white, but in the days of the old train station ticket purchasing machines, I couldn't buy a ticket because they were grey on grey, and I just couldn't read that no matter what size it was. If you've got bad optic neuritis, it takes forever for messages to get to the back of your brain. And when I've had testing done, that was sort of a 0.2 second delay between my eye and the brain. And when you can only get messages through slowly, the thing that's really hard is putting complex pictures together. So I wrote a journal article once where, reading the references I needed to read, I could only read about 3 letters at a time. So to actually read one long word in the reference, I'd have to read it as 3 separate little bits of a word. And there's one particular paper I wrote that I reckon there's blood on every page because it took me so long to do that. And supermarkets became a nightmare because looking down an aisle, I actually got nausea because I couldn't put the pictures together.
Interesting. Now, the optical stuff is obviously a fairly common scenario. And you know, we forget sometimes how connected our brain is to our vision systems and the way we process that. What else has been happening with your body over the last 20 years? And granted, we need to acknowledge there that you're now under Trevor's great care and, you know, so it's not a unregulated scenario we're talking about. It's one where this is the best we can do.
The single worst thing I had was a flare that gave me vertigo, and that was very easy to get attention because I vomited in the day centre at the hospital and they recognised straight away I needed treatment, but that was particularly unpleasant and I'm glad it settled. One of the things I mentioned when I met Trevor, I think he picked up a whole lot of things that other people hadn't picked up, so reflexes that were stronger than they should have been, particularly on my left side, and that's sort of, I call them neurological signs that didn't actually bother me because functionally they weren't impacting me. And that kind of makes me laugh because that episode I reckon I had over 30 years ago was followed by 15, 20 years of complete normality from my perspective. But as a medical student, I was found early on to have very brisk reflexes on my left side, and I was the teaching example for my clinical group because the neurologists loved all my increased reflexes. And that was following on from that episode of what I'm sure was optic neuritis. So it backs up my theory that I've actually had MS since the 80s.
Interesting. Trevor, you know, we're hearing from Catherine now. You know, she's still working, she's functional, she's living her life. Is this an example where MS hasn't progressed too far because it's been well managed, or where does that sit in the range of what MS can look like?
There's a vast range, basically, and I would say that Catherine has been, to some extent, lucky to be living when she is, because I think that we have been able to alter the clinical course of multiple sclerosis since the 1990s. And I suspect, but don't know, that Catherine, before the 1990s, at this stage of her disease, would not be working. That's not to say that things are perfect, but I think the lot of patients has improved dramatically. And I think that there are two aspects to that. The first is the treatments themselves. But I think the corollary to that has been that our awareness of the care that people with multiple sclerosis require has also advanced. And this is the synergy between treatment and what's on offer holistically for people with multiple sclerosis. I think that 30 years ago, multiple sclerosis was an example of a forgotten disease. And there was neglect in terms of attention to a whole range of symptoms, which now we hopefully manage much better than we did before, even though they may not be impacted directly by the immunotherapies that we have.
Now, Michele Binder, you're at the sort of the cutting edge of the research frontier in terms of what we can do about it and what's going on. Can you explain to me what is happening both in Catherine's brain specifically, but in, Trevor mentioned the central nervous system as a whole, which goes, beyond the brain. So what is actually happening sort of structurally there? What's going on?
Yeah. So as Trevor's mentioned, one of the biggest challenges we're facing at the moment in multiple sclerosis research is working out how to treat progressive MS. So what's the main problem with progressive MS is what we call neurodegeneration. That's the loss of the nerve fibres, and that leads to the functional deficits that we see in people with MS. But that is actually secondary to another process that's going on in the brain, that is the loss of myelin, or the protective cover around the nerve fibres. So the loss of myelin leaves the nerve fibres open to damage, both by molecules that are in the brain as well as immune cells that can enter the brain abnormally during MS. So what we know from research around the world in the lab is that remyelination, in other words, the production of new myelin, can protect those nerve fibres before they get damaged. And what we really want to do in my research is to look at ways of enhancing that remyelination. And I say enhancing because, in fact, remyelination is a natural process that occurs in the brain, but it's inefficient and it becomes even more inefficient as we age. So for people who are living with MS for a long time, the process of remyelination becomes less and less useful. But because it's a natural process, we can look for ways to enhance and improve that process.
So a very specific question around that. So the myelin sheath is what protects these essential electrical contacts, is essentially what we're talking about. And with MS, are we talking about a scenario where that remyelination process is no longer efficient or working properly, or are we talking about the myelin decaying in itself? Because they seem to be two, maybe it's both, but two separate processes.
Yeah, so that's a really good question. So in fact, that is two different processes that can prevent remyelination from occurring really well. So the first is that the cells that produce the myelin can become damaged, they can be lost, and they aren't necessarily very well replaced, or if they are well replaced in a natural process, they maybe don't produce myelin as well as they could. And that's one way we would like to treat MS, to directly influence those cells to produce more myelin. But to get to the other part of your question, one of the issues is that when myelin is damaged, it produces debris, just like on a building site. There's rubbish left over if you take down a building, and you can't build the new building or make the new myelin without clearing out that debris. And there's another type of cell, so not the myelin-producing cells, but actually a type of immune cell called microglia. And one of their main jobs is to remove that debris. But one of the problems is that microglia themselves, while they're a really important cell in their response to damage in the brain, whether that's disease or whether that's trauma, if they respond in inappropriate ways or they respond for too long, so in other words, they respond chronically, they can actually become inhibitory to repair. So they don't do their job. They don't remove the debris, and they actually start producing molecules that can cause further damage. So one of the things that we would like to do, in addition to encouraging the myelin cells themselves to assist their survival and encourage them to produce more myelin, we want to change the way those immune cells are responding. We want to change them from being potentially damaging to assisting with the repair. So we want to change them to assist in removing the debris, and we want to change them so that they produce things that actually can be really important for the myelin-producing cells, things that indirectly support the survival of those myelin-producing cells.
Yeah, interesting. Trevor, when you meet with Catherine and you talk about, current treatments and so forth, how much of the current sort of offering sits within the myelin protection or regeneration phase? How much of it is that versus just alleviation of symptoms?
I think there are three components. One of them is the immunotherapy, which helps with targeting the adaptive immune system's ability to damage the central nervous system. And we have effective treatments for that. They're not perfect. We can improve and we can customise those in ways which are not available at the moment. The second is symptomatic treatments. Some of the symptoms Catherine has mentioned, specifically helping to ameliorate those, and we have a number of effective treatments to diminish their impact. The third is neuroprotective and remyelinative therapies. We're not there yet. And this is the hope for the future. And this is why at the Florey we're so interested in concentrating on this, because there are people who are at risk of progressive MS, who are in the midst of progressive MS, who we're still not doing enough for. And that really is the hope for the future, that our research and the research going on around the world will change the lot for people who are susceptible to progressive MS.
Catherine, how has MS affected your life? I mean, you mentioned a few of these individual instances, which I think obviously were scary at the time. You know, they helped you get diagnosed, took you out of the workplace for a little bit. But you've had this for 20 years. What has this meant for you in terms of your family, your career, friends, the whole lot?
Look, it's made a big difference, and some things I can concretely say MS is the cause of that part of my life, and some things I can only postulate because I guess none of us know what would have happened if we hadn't have had a particular issue. But one thing is I'm really glad that if I'm right and I had MS back in the late 1980s, I'm really glad I didn't know because I wasn't unwell in any way, and who knows whether I would have gone on to do physician training, specialist training, 2 postgraduate degrees after that. And although it's not an answer to the question you just asked, one of the most important things for me is that I have qualifications and a profession I love that mean that I can work part-time and survive really easily. And had I chosen to say, well, I'm giving up on medical school because I've got a disease for which there's nothing but palliative care, which is basically what it was in the 80s, I would at best be struggling with a low-paid job. I happen to be single, and if I didn't have a partner, I'd be in desperate financial circumstances. So in terms of once I knew I did have MS, again, I hope Trevor will forgive me for raising our first couple of appointments, but they are indelibly on my brain marked. And one of the stupid questions that I asked Trevor was, what is my prognosis? And the answer which he gave me, which at the time was probably the best answer available, was that he thought it was unlikely I would be working in the job I was working in at the time 10 years from then. That was 22 years ago. At the time, none of the highly effective treatments were available, and at the time, we thought I was having my first episode and had a fair few poor prognostic signs. So that did a few things. I had not that long earlier than that bought my first house. So one of the things was it made me work my butt off to get that mortgage paid off because I was really worried that as a single person with a mortgage, I'd lose my house if I had to stop working. So I worked ridiculous hours whilst getting used to having MS for the first few years. And I don't regret that because I no longer have debt, which is great. One of the more tentative things is if you'd asked me what I wanted to be when I was 6 years old, I would have said I want to be a doctor, I want to be married, and I want to have 6 children. At the time I was diagnosed, I had just finished physician training, and I thought I was being handed a life that I didn't want, let alone wanting to involve an important person in. So I think that my mental health, for want of a better word, in response to that prognosis probably played a really significant part in the fact I never did find a partner whose kids I wanted to have. I certainly met a reproductive health specialist who in my late 30s told me she could get me pregnant, and there's no way I'd be a single parent deliberately with MS. You know, all respect to those who've done it, but it's not for me. So I don't think I'd be single and without children if I didn't have MS. Having said that, at almost 56, I have the best life as a single person with no kids to worry about. And I was saying to Michele outside, a lot of my friends in my age group are openly jealous of many aspects of my life. So I think it's swings and roundabouts.
Catherine's just touched on a really important point, and that relates to people with multiple sclerosis, but it relates to us all. And that is how we deal with the prospect of uncertainty. And in many discussions I have with patients, they're very much concerned by uncertainty. I flip that and say that all of us have uncertain futures. It's just more obvious for those who have multiple sclerosis. Having said that, I think one of the challenges for us is to give people a more realistic perspective about what the future might hold for them in terms of these prognostic factors that Catherine has mentioned. We have some, but they're imperfect. And one of the other aspects of what we're trying to do is develop biomarkers which help determine who is more likely to have severe disease associated with disability in the years ahead, as opposed to those who have intrinsically more benign disease. And that helps people in planning, but it also helps us as physicians in relation to stratifying treatments which are more appropriate for specific people, both in terms of the severity of the disease, but also the drivers of their disease, because I think at the end of the day, there's been a tendency to think of MS as a single disease. I otherwise think of it as a syndrome, whereby there are certain endpoints which may be common or similar between people, but the drivers of the endpoints differ. And we have to become more astute in terms of understanding what those molecular drivers are to be able to inhibit them more specifically and to reduce the side effects of the therapies which might still be otherwise germane.
Trevor, when you speak of a biomarker, do you mean something akin to a definitive blood test, essentially, something where you can pick up something in their blood or saliva or whatever to say, yes, you have MS?
Absolutely. And biomarkers range from imaging, which MRI, magnetic resonance imaging, is part of the standard investigation for multiple sclerosis, both in terms of the diagnosis, but in terms of assessing the activity or stability of the disease. But we need to develop blood-based biomarkers. And I think we need to look to other disciplines in medicine, not least, for example, oncology, where precise medicine, precision and personalised medicine are now to the fore. And although we've made significant inroads in terms of developing treatments which have partial efficacy in multiple sclerosis, I think the end point is that personalised medicine for improved efficacy of treatment.
It's interesting there, Catherine, when Trevor mentions oncology, I'm curious from your perspective, both as a human being and as a clinician. If I present to a workplace or anywhere with cancer, I get sympathy and care and support. What is your view with regards to MS and the bias and so forth? And astute listeners will be aware that we haven't used your full name today in this interview, presumably because of that. So what are your thoughts on that?
There's two main sides of that, or actually three in a way that I'd like to respond with. One is that it's both a blessing and a curse that those of us who have MS without major mobility problems often have an essentially invisible disease. And that's a blessing because we can choose who knows we have MS, but it's a curse. When I was in the middle of that flare where I had bad vertigo and was literally vomiting at the drop of a hat, I was told by a tram driver to give up my seat to a person with a disability because I'd sat in the disability seat and I could not stand up on that tram. So I did the grown-up thing and got off because I'm not going to have a fight with a tram driver who was actually doing a good thing for someone with a visible disability. So one aspect of it is that what is unseen can be both hidden deliberately but also ignored. Another aspect of that, which I think is really important, and I've thought a lot about this, I'm not really sure how to word it, but when you have cancer, you're right, in general, you'll get sympathy. I would hazard a guess if you were diagnosed with a cancer that was non-lethal but had a long-term impact on your life and function, the sympathy would peter out over time if you looked well. And I think the bottom line is that in general, people can't exist in a prolonged state of crisis. So most of the people around me, colleagues, family, friends, etc., are aware that I have MS. But if I'm having a bad day and I don't say so, they treat me like anyone else. Again, blessing and a curse. But, if someone has a pregnancy, when it starts to show, they get some sympathy. They probably get some help when the baby's arriving. But when the toddler's tearing the house down and they haven't slept in 2 years, people have given up. And I think it's a little bit similar that people, unless you tell them, I really need a hand right now, they just can't exist in that perpetual state of treating you as someone who's in crisis. So that's not MS specific. That's any long-term disease. And it is a real problem for some of us at times when we're not doing well. And the third thing is about when you look at what you need at work, for example. So I could write a book on the lack of accessibility of public hospitals in Australia. Where I work, there is no staircase that has a handrail on both sides of the stairs. The electronic medical record is designed so that whatever size font someone enters their notes in, it is impossible to enlarge that on the screen. So all those sort of basic things that in any normal workplace, that would just not be okay. You'd have to be more accessible than that. If you have an invisible disability, you really have to have a tantrum to get what you need in a lot of workplaces, and I'll say in public hospitals is one of them. So that sounds kind of negative in many ways, and I am very grateful for how well I am, but I've also learned that at times I need to advocate for myself because no one else is going to do it.
Yeah, that must be exhausting. I mean, I've seen this myself with family members where they have had invisible disabilities and, you know, in some cases, especially the hospital environments are literally the worst environments. You ask anyone with migraines who goes into an emergency room, it is literally the worst place to go if you have a migraine, but you have to go there sometimes. And so many of those things, if you are not advocating, you don't get a lot of support. I mean, you've been doing this for 20 years. Have you seen changes, improvements over that period, or are we kind of just waking up to the invisible disability aspects?
Not as much change as I'd like. One of the things that I've noticed is I am a much better advocate for my own patients than I am for myself. I find it really difficult to ask for things that I wouldn't need if I didn't have MS. But a huge number of my long-term patients have actually said things to me like, why are you the only doctor who gets it? Because I'll see something that's not working and I'll fight with them to change whatever it is because I just say that's not okay. So I guess one positive of MS for me is I think it's made me a better physician. There are probably times when I'm in a really narky mood and I'm a terrible physician because I'm not feeling well, but hopefully I don't take that out on my patients.
Yeah.
But
to be clear, that you're a more effective, a more low-cost physician when you treat your patients with that kind of care because you'll reduce their repeat. Everything gets better when you are giving them their needs.
I'll certainly fight with them to make the system work as best as I can for them. And if the system needs to change, I will fight hard for that. But as I say, I find it very difficult to fight for myself. And one of the odd things about being a physician with a chronic illness is when I'm the patient, I feel this incredible need not to be the difficult medically qualified patient because doctors as patients have a very bad rep. And it almost makes me feel like I can't say anything that might put me in that group. So I hope I don't.
Trevor is smiling. Trevor, is she in that group of difficult medically advanced patients?
Not at all. Not at all. I did want to touch on one thing, though, which you have covered to some extent, and that is the invisible aspects of multiple sclerosis. And we talk about the neurology of the disease, but one of the absolute cardinal features of the disease, which almost every patient, when you scratch beneath the surface, actually finds, is fatigue.
Yeah.
And that's very hard to quantitate, but I would say that almost 100% of people with MS suffer from chronic fatigue, basically, which fluctuates and it has to be well managed in terms of lifestyle. But we as physicians are bereft, unfortunately, of effective treatments to deal with the fatigue almost universally associated with multiple sclerosis. And this extends to other conditions as well. And we've heard a lot about long COVID recently. And we see the fatigue after infectious mononucleosis. And there needs to be a lot more research done to understand the fatigue which is associated with these conditions for us to be more effective in treating this cardinal feature.
Michele, when you're in the lab and you're dealing with things like the nerves and the myelin sheaths and so forth, I mean, hearing about all these various elements, this whole odyssey of impacts that MS has, how much of that do you think the myelin sheath aspect will impact? And have you seen, in mouse models or anything else, just how far that goes?
Yeah, so I first of all just want to say how motivating it is to me to be able to, chat with people with MS. As, you've touched on, many people know somebody who has MS. So it's a really widespread disease. And when we're in the lab, actually we can be a little bit separated from the people who are living with the disease we're trying to develop new treatments for. In terms of how much we see in the lab of these other aspects, I think that it's really difficult when you're working with animal models to really get a feel for how the animals feel about what is happening to them. And that's one of the big challenges in translating what we do in the lab to actually people with MS. So the first thing to say is our models are exactly that. Animals do not get MS. So it's only something that we can model imperfectly in the lab.
No animals that we know of get MS.
That's correct.
That's interesting.
Yep. Yeah. So we can only model it imperfectly, and we have different models for different purposes. One of the ones that we mainly work with in terms of looking at trying to assess particular molecules for how they might promote remyelination actually has very little evidence that you can see on the outside of the mouse in terms of how they act or behave, in terms even of looking for, challenges to their motor system, how they go running on mouse treadmills, that sort of thing. We personally haven't been able to identify that they really have a difference. So whether that's simply because the model that we work with, one of the problems is that potentially it's not actually a great model for what happens in people. The model that we use and the way that we use it now, although we're trying to develop new ways of using it, actually the mice recover really well, and they do that really fast. So we think that that's obviously not what we see in people with MS, and one of the issues may be that we're giving it to them too young, or we're not giving it to them often enough. There's a couple of hits that we often see with people with MS. As Catherine has described, she had probably a very early unrecognised bout, and then many later on had more bouts that were more recognisable as MS. With mice, we're trying to model that by doing that more frequently, giving them our disease more often.
What are the prospects in the future for your research in terms of utilising our cells? So we're starting to hear more and more about the growth of neurons and all sorts of brain components in a dish from human cells, from stem cells. This is progressing, as we would expect, reasonably slowly, but is that starting to impact the way in which you would be doing your research, where you could actually potentially, Catherine donates some skin cells and whammo, 6 months later you've got, neuronal cells that match hers?
Yeah, so that's absolutely a way in which research is going in order to bridge the gap between testing stuff in animal models and making sure that it works in the same way that we predict in human cells. So before we look to take that to a clinic and, put it in a human, because there have been instances where what we think is going to work in a mouse actually doesn't work in the same way in a human. So I have people in my team as well as colleagues that I work with who are looking to grow, exactly as you say, what we call a brain in a dish. Now, of course, it's not really a brain, but it does have the components of a brain in that it has, human neurons, it has the cells that produce myelin, it has you can add in the microglia that we've talked about earlier, and you can model some of those interactions all in a dish. It still would be a challenge to ask it how it feels. Nonetheless, we can certainly look to understand how our treatments are working in a more relevant cell type.
I'm glad you can't ask the brain cells in the dish how they feel.
Yeah, me too.
We get to that, we're probably in a bit of trouble. Trevor, you were mentioning just earlier about things like precision medicine and so forth, and the component of that is understanding our genetics and how I'm different from Catherine. Are there genetic hereditary components related to someone getting MS? What does that look like?
There absolutely are, and we see this in family studies. if a person has multiple sclerosis, their siblings probably have a threefold increased risk of multiple sclerosis, but still the majority will not get MS. At least 97, 98% of SIBs will not get multiple sclerosis.
So let me catch you there and just say, when you say threefold, what was the starting point? Because 3 sounds like a lot worse, but if my chance of getting it is 0.001%, I don't care. So what's the starting point for the threefold number?
Exactly, and that's where the general population is around 1 in 1,000. But at the end of the day, you can see if you multiply by 3, you're going nowhere near a significant figure. Having said that, in relation to monozygotic twins, where one twin has multiple sclerosis, the lifetime risk of the second twin getting multiple sclerosis is about 30%, and their risk of having MRI changes consistent with demyelination is about 50%. So we know that there is something in families which is running to increase that risk. And that still can be a mixture of both genetics and environment. And we've been involved in genetic studies which have identified about 200 loci in the genome which are relevant in changing the susceptibility to multiple sclerosis. And the most apparent risk is something in what we call HLA, which is a key molecule expressed by immune cells which presents antigen to other immune cells to activate them, and which then leads to that activity being directed towards the brain. Now, that said, we believe that the most significant risk factor, which is almost universal, so necessary although not sufficient, is exposure to Epstein-Barr virus. And generally late in life, where there's a clear-cut association with infectious mononucleosis. Most of us are exposed to the EBV virus in early life, but some late. And this is where there's increased risk of multiple sclerosis. And the latency on average between adult exposure to EBV and development of symptoms related to multiple sclerosis is about 8 years.
Interesting.
And the question there is why some of those people transform to multiple sclerosis and others don't. And that's where we've got to be thinking about genetic susceptibility and where there are other environmental inputs which might be important in transforming that risk to reality.
Epstein-Barr virus, more commonly known as?
Infectious mononucleosis basically is what we identify as being the accompaniment in some people of the EBV virus, Epstein-Barr.
Does it have a broader impact on our immune system in general? It sounds like there's some dots you're connecting here between what the immune system's doing, our chances of getting MS and so forth. Is there some modifying factor from getting Epstein-Barr that changes the way our immune system works overall?
Absolutely. And the Epstein-Barr virus is particularly trophic to what we call B cells, which are a particular type of immune cell which makes antibodies. But that cell can also express the HLA molecule and present the antigens I've just been talking about. And here we have a theory, which I think is a well-enunciated theory of molecular mimicry, whereby some molecules expressed by the Epstein-Barr virus are similar to some of the molecules which we know are expressed in the brain and spinal cord. And so therefore in some people that mimicry is more apparent and the checks and balances to keep it regulated are not there, and that leads sequentially ultimately to activation of the immune system in inappropriate ways. And once again, back to the oncology analogy, I think we're seeing now potentially this stepwise process, not just one hit, but a variety of factors coming together serially to transform risk into reality. And obviously we need to be understanding that much better than we do. And once we do, hopefully we can put brakes on the process even before symptoms have generated, basically.
Now, just coming back to you, Michele, if all of a sudden a very large truckload of cash turned up to support your research, what direction would you go in with that if, suddenly there was a big infusion of support? Because it sounds to me, when I hear about MS and I hear about the money going into it, it seems to be grossly disproportionately low compared to other conditions that lead to lifelong disability or chronic illnesses.
Yeah. So if I had this mythical truckload of cash, I would really be looking to work on two different ways that I hope would improve remyelination and therefore protect nerve fibres. So the first would be to identify molecules which can directly support the myelin-producing cells. We actually have one that we're currently working on that we're very excited about, and it's been shown in the laboratory to improve myelin repair in animal models, but it's challenging because it's a big molecule, and in the normal state of affairs, big molecules can be excluded from the brain. So we're looking to adapt that molecule or potentially think of other ways that we can get the molecule into the brain to directly improve the way the myelin-producing cells are surviving and producing myelin. So that's one way that we'd really like to take further and develop. And the other would be to look at ways in which we can modulate the behaviour of microglia, the immune cells in the brain, to produce an environment that's actually much better for remyelination. We know from other studies that if there is myelin debris remaining in the system, that is actually inhibitory to myelin repair. And as I mentioned, the microglia in the brain are long-term in people with MS are probably not our friends. They're probably not doing the things that we really want them to do, which is to remove the debris and to produce factors that can support the myelin-producing cell. And one way that we're really keen to develop ways of changing the way that microglia behave using what are small molecules that are known as microRNAs. Now, these molecules are found in all our cells, and one of their benefits, as you might get from the name, is they're very small. So we think that they're getting them to where they need to be in order to affect the behaviour of the microglia will be much easier. And one of the other great things about the microRNAs is that they're what we view of master regulators. So we think that you might only need one or perhaps no more than a handful of these microRNAs that can completely change the way in which the microglia are behaving. So that's something we're working really hard on. We're looking to identify microRNAs, and we've identified some that can promote the way that microglia remove debris, and we're looking for others that can change the types of factors they secrete to really change the whole environment in the brain so that even potentially the endogenous remyelination that occurs, the natural remyelination that occurs in people's brains can work better.
Michele Binder, thanks so much for chatting to us today on the Brain Matters podcast.
Thank you, Shane.
Professor Trevor Kilpatrick, good to see you again. We've done this before.
We have.
So I think, we've had these discussions over many decades to hear about some of the amazing changes that are occurring in this space, and great to hear that you're still working as a clinician helping many people.
A pleasure. Thank you, Shane.
And Catherine, it's been inspirational hearing your story. I think, dare I say, anyone listening to it would agree that you are a better doctor for having MS. And it sounds like you live in a very happy life, which I think a lot of people would listen to the joy that you speak about and would be somewhat envious. So as much as I suspect it has been an incredible challenge for you, I congratulate you on everything you achieved.
Thank you very much. And may I advocate to improve my happiness that someone should drive that truck full of cash towards Michele's lab.
Absolutely. Thanks so much, Catherine. I hope that happens, Michele.
Yes, that would be fantastic.
Yep. You've been listening to the Brain Matters podcast, brought to you by the Florey Institute of Neuroscience and Mental Health. Join us for our next episode on brain health, and if you have a particular topic you would like us to cover in the future, please drop us a comment or send a message via the email in the show notes. I'm Dr. Shane Huntington. Thank you for listening.